Welcome, everyone. My name is Annette Johns, and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador College of Social Workers. I have the honor of being the moderator for today's education event, Building Collaborative Relationships and Fostering Cultural Competency in Providing Safe and Effective Services, along with my colleague Peggy Rauman with the College of Registered Nurses, Newfoundland and Labrador. We have hundreds of healthcare professionals registered for this event this afternoon, so that is excellent, and we welcome you all here. Today's webinar is a collaboration between the Newfoundland and Labrador College of Social Workers and the Canadian Association of Social Workers, the College of Registered the College of Registered Nurses, and the College of Licensed Practical Nurses. And it's always so wonderful when we can come together and engage in some collaborative learning to enhance our knowledge and skills in providing high quality services. Just want to give you some information about how the event is going to happen this afternoon. The panel presentation will be approximately 90 minutes, followed by a short question and answer period that Peggy and I will moderate. Please note that all the details you need, like how to access any of the presentation slide decks, handouts, and other housekeeping information, is included in the announcement and housekeeping widget. And all the widgets can be accessed by clicking the blue and white icons at the bottom of your window. And you can also resize and move around any of the elements on your screen to customize your viewing experience. During the presentation, we encourage you to type in any questions you might have for our panelists using the question mark icon at the bottom right of your screen at any time, and we'll begin asking them at the end of the presentation. Please note that only the presentation team can see the questions. So we are joined today by 6 stellar panelists whose bios are included in the bio widget in your platform. And I just want to take a minute to briefly introduce them. Vernon Curran is the Associate Dean of Educational Development and Professor of Medical Education with Munn Faculty of Medicine. Chief Eugene Hart is the Chief of the Sheshatshiu Innu First Nation. Megan Hudson is a tuberculosis public health nurse with Inuktitut Government. Chief Missile Joe is Chief of the Mi'kmaq First Nation. Jessica Lyle is a social worker and the Child and Youth Mental Health Clinical Lead with the Department of Health and Social Development with Inuktitut Government. And Brian Pittman is a licensed practical nurse and lead instructor for the PCA program with the College of the North Atlantic and member of the Halapu First Nation. What a truly wonderful panel. In welcoming all our panel partners here today, we acknowledge that our beautiful province is the ancestral homeland of many Indigenous people, including the Beothuk, Innu, Inuit, and Mi'kmaq. We respect the history of the land and the diverse cultures of all Indigenous peoples and promote the importance of truth and reconciliation. The Truth and Reconciliation Commission of Canada released their final report and calls to action in 2015. Among the 94 calls to action, the provision of cultural competency training for all healthcare professionals was highlighted. As healthcare professionals, we are committed to providing culturally safe services, and this requires ongoing education, knowledge development, self-reflection, and a commitment to fostering collaborative relationships. In 2016, the NLCSW produced Standards for Cultural Competence in Social Work Practice. This document can be found in the handout section of the webinar platform. And while it was developed for social workers, these standards have applicability to all healthcare professionals, as it provides a framework from which professionals can reflect on their knowledge and skills and abilities in working with individuals, families, groups, and communities from diverse cultures. The use of the word cultural competence in the document was used in a purposeful way as an umbrella term to reflect the knowledge and skills practitioners need in providing safe and effective services. It incorporates cultural sensitivity, awareness, humility, and recognizes cultural competence as an ongoing process, not an endpoint of learning, reflection, and professional growth. While one cannot be competent in someone else's culture, it is important that we seek to understand our own culture and the cultural experiences of people with whom we work, their values, traditions, beliefs, and history. This is important in building collaborative relationships, and I look forward to hearing from the panelists today as we delve deeper into these issues. I'll now turn things over to Peggy as she welcomes each panelist.
Thank you, Annette. That was a wonderful introduction. My name is Peggy Rauman, and I'm one of the nursing consultants for policy and practice at the College of Registered Nurses of Newfoundland and Labrador. I am very much looking forward to the knowledge that will be provided by our speakers today and for the discussions at the end of the presentations. So to begin, I would like to now invite Vernon to speak as our first panelist.
Great. Thanks very much for that introduction. Hoping you're able to hear me okay. So, pleasure to join you today. As mentioned, I'm Associate Dean of Educational Development with our Faculty of Medicine, and I oversee our professional development office here in the faculty, which has responsibility for developing and providing accredited continuing medical education and continuing professional development programming for physicians and other healthcare providers in the province. What I thought would be useful in discussion with the panelists in their planning and preparing for today, I thought I would talk a little bit about some of the concepts which are important. And many of these concepts really, we can treat them as being considered stages or phases or steps towards cultural safety as healthcare providers. And just to start with some of the different concepts that are talked about in the literature, but also when we're thinking about cultural safety, there's a number of different concepts. And again, these can be treated as phases or steps or even stages towards building cultural safety in our practices and in our clinics and other work environments. So an important first stage or step is referred to as cultural awareness. And this is a stage or a step where we are learning about the fact that other cultures have different languages and behaviors and traditions. So learning that other cultures have different values and beliefs from ourselves, and trying to gain a better understanding of how this can help us or shape our approach to patients from other cultures, cultures other than our own. Another important step or stage is referred to as cultural sensitivity, and this has to do with developing a better understanding of ourselves and our own actions and beliefs and behaviors, and if there's any aspects of those beliefs that might be insensitive to others from other cultures. Cultural competence is another step or stage or concept that's discussed when we're thinking about cultural safety or achieving cultural safety. Cultural competence has to do with a willingness to learn and understand and accept that other cultures have different views than our own cultures in terms of their approaches and understandings of their own health and wellness. And as part of cultural competence, it includes trying to develop a better awareness and understanding of how the cultural and historical and political issues may have affected or have affected and impacted Indigenous people. And a key point here that was just mentioned was we can really never become competent in others' cultures, but learning about those other cultures, becoming more aware, and developing a sensitivity towards other cultures is an important step and phase towards becoming developing cultural humility, which is another key step, and this involves an acknowledgement of ourselves as willing and wanting to learn about other cultures and understanding experiences of patients and clients from other cultures. So these steps and stages or phases are really helping us build up to developing and fostering cultural safety in our practices as healthcare providers or social care providers, and in achieving or trying to develop cultural safety in our practices. It involves looking at ourselves and our practices, our work environments, and reflecting on our own cultural identities and reflecting on how our own identities may impact the culture within our own clinical practices or social care practices. And a key part of this is developing a critical consciousness, and that involves this reflection on ourselves and on our practices. And a critical consciousness also involves acknowledging the power imbalances that are inherent or exist in the relationship between ourselves and also the patient client, and also acknowledging and addressing our own biases and attitudes and how those might affect our provision of care to patients and clients from other cultures. So an important part of cultural safety is developing this critical consciousness where we're reflecting on ourselves, our own biases and our own identity, and how those biases and identities may influence our practice in interacting with patients and clients from other cultures. So there's a couple of diagrams that I wanted to share, which break down these different concepts and these stages and steps. So this first diagram highlights many of the concepts and stages: cultural competence on the left side, cultural safety on the right side, and in the middle it indicates how important part of achieving cultural safety is developing a knowledge and awareness of the beliefs and traditions of other cultures. And as part of developing that knowledge and awareness, it helps us to become more culturally sensitive to the beliefs and traditions and languages of other cultures, and the beliefs and traditions and understandings around how other cultures view and approach their own health and wellness. And with cultural safety, it involves, as well as this reflection on our practice and our own beliefs and ideas, it also has to do with looking at the patient's perception and their feelings around the safety that they perceive and receive when they're interacting with us as healthcare or social care providers and receiving care in our, the clinical environment or a practice environment. So it's really about how safe does the patient or client feel as part of the interaction with us as healthcare providers and social care providers. And another key concept that's mentioned here is cultural humility as well. And that has an important implication for us as healthcare and social care providers in that it places an onus on us to demonstrate humility in terms of our willingness to want to learn and understand more about the beliefs and traditions of other cultures, and also our patients or clients' beliefs and traditions as it relates to their own health and wellness and their beliefs and traditions around health and wellness from their cultures. So this is another diagram that breaks down these steps and stages as well. So again, cultural awareness is a first key step and stage in helping us as healthcare and social care providers understand and become more aware around other cultures, patients and clients from other cultures and their beliefs and traditions. Cultural competency is highlighted here in this diagram as well, in terms of being another important step or stage. And it involves oftentimes can be educational phase where we're learning more about or developing this cultural awareness. But again, an important point that's made by many is that it's hard to actually become competent in others' cultures. So becoming aware and becoming sensitive to the beliefs and traditions of other cultures is an important step towards achieving cultural safety. And again, cultural safety is highlighted here as a transformative understanding that we have with our clients and patients. And a key point with cultural safety, again, is that it really has to do with the perception and feelings and experience of the patient or client in their interactions with us as healthcare or social care providers. This is another key diagram, which again highlights these key steps or stages or phases towards developing and fostering cultural safety. And in this diagram, the authors talk about, the first stage being cultural awareness, which is, again, where we're learning about other cultures. And as part of that learning, then we would be hoping to develop cultural sensitivity, so becoming more sensitive around the beliefs and traditions and languages of other cultures, and also the beliefs of our patients and clients from other cultures around their health and wellness and their approaches to health and wellness. Cultural competency and cultural humility are also mentioned in this diagram as other important stages towards achieving cultural safety. And cultural safety, again, is the ultimate, outcome or stage that we're trying to promote and develop. And again, this involves this notion of reflection on our practice and on ourselves and our interactions with our patients and clients. And a key question that can be asked here, we can ask of ourselves, is how safe and comfortable, but also affirmed, do our patients and clients feel while they're interacting with us and in our clinical or social care practice environments. So it's really about the perception and experience of the patient and how safe the patient and client feels in their interactions with us, but also the health or social care system. But an important part of developing and fostering this cultural safety is also is learning about other cultures, developing the cultural awareness and cultural sensitivity towards other cultures. So in trying to enact cultural safety, the focus is really moving from the culture of the clinician or the clinical environment, and ultimately, again, it's the patient or the client who decides whether or not the care was safe. So it's, again, really important to have that reflection, develop a reflective approach to our practices in terms of our own awareness and sensitivity, our own beliefs and ideas, and how those might create a bias towards our patients or clients from other cultures, and becoming more aware and sensitive to the beliefs and traditions of other cultures, and what we can do to enhance that experience for our patients and clients and their experiences with us, to help them feel safe in their interactions with us, but also in their interactions with the health or social care system, and also within our clinic environments or our work environments, interactions with with other staff from the time that a patient or client enters that particular space. So some ideas around how to promote culturally safe practices. Obviously, becoming aware and developing that sensitivity are important, but some important points around culturally safe practices. And I'm certainly looking forward to hearing from the other panelists around their own personal experiences. But these are some things that are discussed and highlighted. Is respectful encounters is obviously very important. Treating our patients and clients as inherently worthy and equal. Having conscious communication and listening. So again, that involves this critical consciousness where we're reflecting on our beliefs and values and ideas, and how that may actually impact the types of questions we may ask of our patients and clients. So developing that cultural sensitivity and awareness in terms of our approach and our interaction and how we communicate with patients and clients from other cultures. Trying to set aside an adequate amount of time for our patient or client visits or interactions, considering how our beliefs and values and also the health or social care system has been challenging or created barriers for Indigenous peoples and their health and well-being, and acting as advocates for making change in those systems to make those systems more culturally safe, and thinking about the experience of the patient or client from the time they step into our clinic space or office space and are in interactions with them. How safe do they feel entering our spaces and in interactions with us? So I just wanted to highlight some work that we've done through our office here in partnership with the Indigenous communities across the province. We've developed a course, a continuing professional development course, and this has been in response to the Truth and Reconciliation report, where there was a call to action to provide more training and education for healthcare professionals. And our faculty and staff from the Faculty of Medicine worked in partnership with our many different Indigenous communities across the province and representatives from those communities to develop a course on cultural safe healthcare for Indigenous peoples. Our hope is this course is going to become freely available and open access in the very near future. And at that time, I'll be reaching out to the colleges of the registered nurses and social workers and also licensed practical nurses to share with them more information on how members across the different healthcare professions in the province can access this course as an open access course. The course itself provides a very nice overview of different aspects of the history of Indigenous peoples in the province and in Canada, the impact of colonialism, the beliefs of our Indigenous communities around the health and wellness. And also there's a key module on providing culturally safe healthcare, which covers in much more depth some of the concepts and phases and stages that I spoke about in this quick presentation today. So I think I'll pause there. And again, thanks for the invitation. And again, we will be following up in the near future to share more information about the course with the different healthcare provider groups in the province. And our hope is to have this course made open access so we can make it available for more health providers in the province to learn more about cultural safety and the different aspects of how to foster and develop cultural safety in your practices. Thanks.
Thank you very much, Vernon. Having a solid understanding of the terminologies that are surrounding culturally safe practice is extremely important. And I have taken that course and I found it very educational and very insightful. So thank you for opening up this session with your presentation. And I would now like to invite Chief Hart to speak.
Can you hear me? No? The mouse is not quite working. We can hear it. Okay, you can hear me. You can hear me. I'm not used to Shannon's computer here. Hi, good afternoon, everyone. I'd like to thank the opportunity that came from Annette Johns. I met her in St. John's at my presentation, and I'm proud to be here today to do a little introduction of myself and a background history, and just to go from there. So, and thank Brian for your first presentation. That was very productive. So, first of all, Chief Eugene Hart from Sheshatshiu. Born and raised in Sheshatshiu all my life. I'm 43 years old. I'm a chief now on my third term, and that's really a breaking record. There's never been a chief for a third term in my history yet. So my dad is from the island, and my mom is from Sheshatshiu, and just to talk about a brief background of my history, my parents, my mom's parents were elderly, like they were in the 90s when they passed away, and very spiritual, very into the culture, and yeah. And my dad is from the island, but my dad moved here 46 years ago. So he's part of Sheshatshiu now. He's always wanted his status card, but I was saying, like, you don't qualify yet. So before I became a chief of Sheshatshiu First Nation, I was working at the school for 15 years. And I was school liaison for a number of years. And then on the last 5 years of my education role, I was the Innu vice principal, the third Innu vice principal in Sheshatshiu. So I decided to move on to different challenges that come along as being a chief. And trust me, there's a lot of challenges. So when you look at the history, I'm going to go start right away with the history of the social work in Sheshatshiu. My first goal when I became a chief was, I'm sure everybody's aware of the situation, the history, and if you don't know the history, you'll learn some of it today, is that me and my wife have been foster parents for the last 15, 16 years, and I grew up in a home where my mom and dad fostered kids, and they adopted kids along the way. So when you look at it, when you look at the system, that's why I was more eager. The interest was there for me to work with the province and the feds with how to bring home our children. That's not in our territory, I should say. Say, for example, there's been kids that were removed from Sheshatshiu for many, many years, and a lot of them came back, couldn't stay because they couldn't adapt to the community, but many majority stayed. So my goal was, when I got in, was we're going to bring children home somehow. We're going to make it work. How is it so far? Is it clear? Or the voice, is the mic clear? We met with the province the first year I became chief, and I had a lot of issues with that. My role was people were calling me to help them with their children, or cops and child youth are at their door. I'm like, I'm going to change this, but not overnight. It's going to take time. So we went to the province, and I said, it's time to bring these children home. I don't know if you see a clip. We went to Toronto on Canada Day to crash a picnic that Catherine, Aboriginal financial minister had, Caroline Bennett. We crashed her picnic, and we weren't invited, but we welcomed ourselves. So we decided to crash her picnic on Canada Day, and we were adamant that we want to meet with her. And we were very grateful and thankful for the people that were from there. They let us past them to hear what we had to say at the picnic. So anyway, it was discussed after that, after we crashed the picnic, that we want our own facility in our own community to run our own Indigenous Innu-led program. So one day when I stepped into the meeting in the province of St. John's, so I made a deal with the province. I said, I'll build a home in Sheshatshiu with our own funding, our own resources. I said, if you help us with the funding. So they said, yeah, we'll do that. So they didn't expect me to do this in 6 months. So the home, the 8-bedroom house, the duplex was built in a matter of 6 to 7 months and was established and ready to go. But what happens? No funding. So we were fighting and fighting and fighting until we got to the bottom of it where we wanted to be. I tell you, it was a lot of negotiations going on then. But now, when you look at the picture now, looking behind me, we have an annual-led program started in Sheshatshiu. We have a facility for 0 to 16, and then 16 to, no, 0, what's the ages for group home? Okay, it's one is from 0 to. Okay. So the numbers are from, when you look at it, is the group home is from, there's a youth group home and a children group home. So now we have 0 kids leaving our community at this moment. We probably have a few for emergency reasons, but at the moment, kids are placed in the community and the parents get the help they need and the child goes back to their care. It gives more connection where it's coming from our community. It gives them more connection. Okay, I'm a parent that's struggling and I know that the child is in the community and I want to get help from the support of the programs that's involving around this. And I did see a lot of kids since we opened up both facilities, a lot of kids return home. And I have a really good communication with the social workers in Sheshatshiu and the nurses. There's actually 2 nurses here online now, Trina and Lisa, which we're very grateful to have. But trust me, this came from a rough foundation until we can. It had to be rough before we can complete the foundation, because this was new to us, and now we're probably going on our second year running it. And so far we're getting really good reports, and it's I'm proud to say that we brought this to our community with the help of the former leaders that were involved and the community health officials that helped us out through along the way. And I think we came very far for this. And a lot of children has returned home, but there's still a few children that need this. We're working on to bring them home. And because I'm always the front line. I'm trying to let the community know there's workers there that you need to call first before I get involved. I don't like to get involved and not get the staff to do their duties, what they need to do. But when we do get a call, so last week we had a call with one of the clients that's in treatment and a recognized treatment facility that got her kids back while she was in the program. And I can guarantee you that's the first time I've heard, we had the judge, we had the social workers on the phone, and she spoke herself and she spoke her mind. And halfway through her program, now the children are gone with her to Nujimit, which is outposts in the program, and they're joining their kids with them. So this is just a prime example of what I'm talking about here, where I started off, but there's still a lot of heavy duty work that's surrounded with this. And so within the first 3 years, it was I was able to work with the province and the FIS, what I said there before, and to upgrade the group home and the facilities we have in the group home. Was a lot of work, was a lot of licensing involved, and it wasn't an overnight thing. And there was a lot of delays, as is common in governments. They like to delay. And we had a really good regular communication with Deputy Minister to discuss everything that we needed to be implemented in our community. And still sometimes, when you think of it, sometimes in the role I'm in now, from the educator to the chief of Sheshatshiu First Nations, I see people coming in. I see people going. I've seen that basically in every job I had. And there's some there that stay, some there that there just because they want to be there, or some their heart is there. And I totally understand that. Like if you don't fit in that criteria, you make you work yourself out of there, which is good. At least you're not kicked out of there. Basically, that's the only answer. Because the ones that want to stay there, I find the community adapts more, and you get the respect more as you need as going by as an employee. Eventually, the community accept you. They accept your who you are, and you accept who they are. And it makes the process easier because sometimes you know when someone's really fitting in good in the community because they have a really good communication with the community. And the social workers we have now, even though it's fly in, fly out every 2 weeks, their program is really, it seems to be working. And we have same thing with Nawashish. We have 2 weeks in, 2 weeks out. But I think in the long run, is like anywhere you go. I think culture diversity workshops or trainings is very important because when you look at it, you don't want to say something that you don't mean it in that way. It's just that there's just so many meanings that could mean something. Either you're trying to learn, but in different way. You don't want to say it in a bad way. I don't know this easy way to explain it. Like you don't want to be insulting. There's many ways it sounds good, but to us it might sound totally different. But it's I find the more you're eager to learn, if you're really interested, you'll make mistakes as you go, and people will tell you the difference, not get mad at you, but they'll teach you the difference. And because I had a lot of staff that I worked with for many, many years, and the problem that the students used to have with the new staff, I can guarantee you that, is the students are smart. They're smart kids. They know if that person's going to be here for 1 year. So if you let the students know you're only here for 1 year, you're not going to get the respect that you should be getting because the students are looking at you differently. Oh no, he or she's not here for very long, so they don't care. That's how they see it, because that's what I learned when they were brought to my office. That's what they're the only year, but the ones that's been there now, say I've been there since the school opened, the new school, their staff still there for the past 13 years, and the students love them. They're basically a part of the furniture. But it's very touchy when you speak about. There's a lot of everything is on thin ice. I find when you're dealing with Indigenous people in our community, because we don't know the history of the child's background. We don't know the history of the elder's background. So we got to be careful, either if the child or an adult, how you present to them, because we could just bring back something that they went through. We just got to be careful in our wordings. You got to be very careful. And it's always important to have an elder at an opening of a meeting, especially in Sheshatshiu, because it's important to have that to give the good spirits, the good vibes, and just a more welcoming feeling to have a good meeting and end off good. But I'm very pleased to be on here today and speak about where I come from and what I do in my community. And it's important to be heard sometimes, because sometimes people don't really know what Sheshatshiu has been through or what success we had going, because sometimes we hear is negative. And it's not all about negative. There's a lot of positive that happens too. And that's the part the media don't really play on CBC. And like the COVID, for example, is hit hard in Sheshatshiu, but luckily we haven't lost anyone. And but other communities has around us, and other Native communities in Quebec North Shore. So hopefully this COVID now will ease down a bit, and then we'll move on to norm because it's affecting a lot of people. And but I'm sure you guys will hear a lot of stories throughout the day, and maybe semi-stories, but every story is different. Everybody has a different story to tell, and it's important to be heard. And I'm very privileged to be honored here today to speak a little bit of Sheshatshiu. And when you think of it now, is like the government is offering children that were taken away settlements. And this is what I'm hearing this week. I don't know, it's the government keeps offering, and then you try to heal and then they open wounds again. And I think that's like a lifetime going battle. And like there's residential school, and there's like RC school, RC church days back in the day. And then the Saskatchewan, when they found the children's graves, and everything is just opening up around us. How I look at the world a different way now since all this, and especially becoming a chief of the Sheshatshiu First Nation, and you hear the hurt and the surroundings of each community. What they're going through is basically there's a hard hit in each community across Canada that were hit in many ways, and there's a lot of healing involved and a lot of support. The only thing that will keep your community going forward is having lots of support implemented in your works, in your mental health, and your because we have a Mary May Healing Center, and we have a Charles J Treatment Center, and we have an Oppenham's House, but sometimes that's still not enough for our community, because we have a community of population of 2,000, and we have a lot of youth. 500? Youth. Yeah. So we have a lot of youth in Sheshatshiu. Like our numbers are high. And but if you got any questions along the way, don't feel like you can ask throughout the other presentations. It doesn't have to be right away, or people can email me and let me know what kind of questions. No questions is stupid. We'll answer them as fast as we can. Good. Thank you.
Thank you, Chief Hart, for sharing some of your history and your experiences and some of the success stories of the youth in your community. I would now like to invite Jessica to share some of her insights.
Hi, everyone. I'm assuming you can all hear me. If you can't, I'll just wait for a message to flick across my screen saying that you can't. So I'm Jessica Lyle. I work for the Nunavut government as the Child and Youth Mental Health Clinical Lead, and I'm also a beneficiary or a member of the Nunavut government. So thank you for the two presenters that were before me, and I appreciate what you both said, and thank you to the organizers of this panel for inviting me to this space. So I think this panel is attempting to answer some really big questions here, and I appreciate being invited to the platform. I first want to say that what I share in this panel may not relate to what culturally competent practice means for all Inuit, and certainly not for all Indigenous folks, but this is just a glimpse as to what I've seen in social work practice so far. So I guess by trade, I'm trained as a social worker, and I work in the mental health and wellness field. The other thing I wanted to add was that my own personal judgments should not be imposed onto others, and certainly not to those who have a differing culture than me. And I think that just kind of encapsulates what we're trying to answer today with this panel. I hope today that this sparks, if this is the first time you've attended something like this, I'm sure it's not, but sparks some ideas in your head. But moving beyond that, I hope it sparks action, not just conversation and ideas. There's a lot of confusion when the word culture is thrown around, because when someone asks you about it, it's such a broad topic. It's a word that encapsulates how people live, their outlook on life, and how groups of people are living. So when we hear culture, and I think more specifically when we hear culture next to words like indigenizing social work practice, indigenizing healthcare practices, or just the two words of Indigenous and culture, I think many of our minds go to cultural activities. So for Inuit, people think about the cultural activities that we participate in: throat singing, drum dancing, hunting, fishing. And while I think many of us would agree that is a part of our culture, when we talk about culturally competent practice, we aren't asking for folks to just accept those things. This conversation is more about that, more than that. I'll use a real example that we see often in social work practice. So in 2019, CSSD, I guess the governing body who overlooks child protection currently in our province, said that for every Indigenous child that came into care, something called a cultural connection plan would be developed for them. And essentially, this document is to help keep children in care connected to their culture and community. I think we've all heard the overwhelming numbers of Indigenous children in care, and for Labrador's landscape, we are no stranger to Inuit children being removed from their families, community, and culture. What this policy attempts to do is to bridge the gap, that it's the understanding that Inuit children in care deserve to still be connected to their culture. And essentially, at the core of it, it's a great policy, and there's been a lot of groundwork to get that policy rolled out. At Nunatsiavut, we have an Indigenous representative, and her name's Krista Mogridge. She's a social worker herself, and she's also a beneficiary of NG. She's our person to help support the cultural connection plans. Oftentimes, what the Indigenous reps rolled to do, and specifically for NG, is to advocate for families to help ensure cultural continuity is there. And again, this is a pretty broad scope of work to be fulfilling. But where I feel it is simplified, oftentimes Krista or other NG social workers will explain that her role is to voice the needs of the family so that the child or youth is connected to their culture. So essentially, she's not dictating what an Inuit family is wishing, but she's really trying to amplify what their wishes are. Many times for folks who are not Inuk, their minds often go to the surface level things, the things that I just talked about. The things you see us physically doing, like ice fishing, sewing, drum dancing, those types of things. And while we never discourage these things being put into a plan, if a family identifies that is what they want, the policy surrounding these plans was and is to help ensure that what Inuit identify is needed to keep their child connected culturally is what should be part and center of the plan. When we see these plans come into fruition, when we're feeling like the cultural connections are being achieved, is when there's not only support to follow through with the plans from systems outside of NG, but is when they also validate why the family is highlighting what they see as cultural connections. And I think this is part of the question we are attempting to answer on this panel. And my simplified answer as to how we can foster cultural competent practice is to center the voices of those from that culture and bring life into what they're saying. And the second part I think about this is when you are pulled into these conversations, having the self-reflection and self-reflexivity to understand that because we are so often in spaces where non-Indigenous folks' voices are at the center, we are not asking for your spotlight to be placed onto us. We are simply asking for another light to be added into the conversation. because so often it can become an us against them focused. And for Inuit, I don't believe we are asking for that. Because when we say to center our judgments when it comes to decision making, we aren't asking for the spotlight to be taken off and to be handed over to another culture to decide what is right for everyone, because that would essentially be colonialism. But what we are saying is we can make attempts at living as a symbiotic relationship where both groups benefit from each other, or in this case, all groups. We're not asking to only be drawn into these conversations and decision making, but that when we say something is culturally inappropriate or you have overstepped your boundaries, this isn't a conversation that is us against you, but one that is saying, hey, we've called you in for what is being decided over us, and this is not align with our cultural outlook. So this brings me to the next point, being called in or being called out. I like the phrase being called in because that's exactly what we're attempting to do. And these are never easy conversations to have. And when you're being called in, it often feels like you are being called out. No one wants to be in the position where they've been identified as someone who isn't being culturally safe. And when you're told you're not being culturally safe, it's essentially another way to tell you that this is racism that we're experiencing. And again, I think we all like to think that, of course, I'm not the racist in the room, I'm culturally safe. And that narrative puts us in a spot where we start thinking about this only having two sides. So on one side, we have those who are not racist, and on the other side, we have the racists. But we really need to flip that narrative on its head because it isn't serving us. Being culturally safe isn't being able to know everything about every culture, and I think our other presenters have highlighted that. We aren't expecting you to take on our cultural values, but we are asking you to give us the same space you do as your own culture. Though that my way of doing things may differ from your way, and that criticizing the way in which we do things is not making a culturally safe space. In social work practice, from what we often see, is still a very colonial attitude. And as often as folks are tired of hearing groups say they're experiencing racism, those of us who are experiencing the racism are tired of having to fight against racist mentalities. So how can we create a system where it is culturally safe? And a space where when we call systems, organizations, groups, or people out when we are feeling culturally safe, we are creating for a system that essentially does not allow for it to be supported. The example I will use that isn't mine, but that is really helpful. I think if we think of cultural safety in the ways we support others so that there are systems in place to not allow for it to continue, we are thinking of a world where we are all working together for this to be implemented, not just those of us who are racialized. When we think of having wheelchair accessibility spaces in offices, what needed for that, for this to be implemented? We needed for ramps to be installed, appropriate doorways that were wide enough, and those types of things. We have created a system that whether the wheelchair accessibility is needed in that moment or not, it has been implemented. Because when the time arises for when those accommodations are needed, they're already there. No one is saying that by implementing wheelchair accessibility is it putting one group's needs over the other. Because when you view cultural safety as something as a requirement, and it is a system in place that does not allow for racist mentalities to continue, it's no longer my opinion against yours. It's a way of supporting people so that they can be appropriately accommodated. And if we think of that example, it would be wildly inappropriate for those of us who are able to walk to say things like, I accept that there are people who need wheelchairs, but I don't want this affecting my workplace. So I'm not in support of having wheelchair accessible ramps. Or I use stairs every day and I don't want the ramp impacting how I have to come into work now. Because that would be absurd. Our response to these accommodating spaces is we see that this is a need so that we can better foster accessibility and fairness. And that's what we need in thinking about cultural safety. Thank you.
I am now going to invite Brian to do your presentation.
Thank you, Peggy and Annette, for the introduction. And thank you for inviting me here today. My presentation is going to be on biases in the healthcare system and how you can identify your biases. And I hope you can hear me because I did have a little problem with my microphone earlier. Computers and myself don't agree very often. Do you feel like you make decisions based on your biases? And I can almost be certain that you do. Many of us believe that we do not, and may be defensive or offended if someone accuses us of stereotyping or making a biased comment. However, the reality is that most of us owe implicit or explicit biases in some form, and these biases may even impact our decision in the workforce. There are many factors that can lead to bias in the healthcare sector, like gender, race, age, religion, and I'm sure the list can go on. First, you be honest with yourself about the stereotypes that affect you. And in order to create an inclusive and culturally competent healthcare system, it is important that we all identify and acknowledge our own biases. For example, you may consciously think that men and women are equally effective leaders. And as a woman, you may believe that men don't have the same level of empathy as a woman. And that would be an example, like probably like working in on palliative care. You have to be an empathetic person, and sometimes men are not. Or as a man, you may not believe that women are physically strong enough for the job. And in healthcare, I'm kind of a little bit guilty of that one myself, because if there was somebody that was an heavier patient, I would say to the female staff member, we can switch job, we can switch residents if you can't, if that person is too heavy for you to handle, which is kind of a bit on the bias side there too. These views can affect how we assign roles and tasks in the workplace, and like I said, we can by saying we can switch residents. We must accept that we all have a different worldview and lived experiences. This view impacts how we see each other and how we as healthcare providers care for our patients. Making decisions solely based on prejudice can have devastating impacts on nursing care that you provide to your patients. And the first step in addressing the impact that bias causes is identifying your own biases. And like I said, we're all guilty of having some type of bias. You may favor a physician or nurse from your own background, or perhaps you are concerned about having a language barrier if assigned to a healthcare provider who is an immigrant. Likewise, you may prefer to care for someone from your own background instead of an immigrant. Once you've identified your biases, you can move to the next step, is acknowledging those biases. And many healthcare professionals don't see themselves as being biased, like I said, and our patients may be negatively impacted because of those biases. This may look like favoring one patient over another, or making assumptions about an individual's language skills or lifestyles, using outdated or offensive terminology, or even making a judgmental comment or facial expressions. It is unlikely that most, if not all of you, have witnessed another healthcare worker demonstrate bias, whether it was in front of a patient or in private. I think if you think back over some of the shifts that you worked, you may come up with some of those incidents. One of the healthcare facility that I work with, we have a recreation worker that brings in some of the Aboriginal, well, for instance, she had an Aboriginal women's group in there and they were doing drumming and they came dressed in, they had the regalia on, and you could overhear staff members saying, that those uh, uniforms that or costumes that they're wearing is not very nice, or making comments about their drumming. They need to go back to some drumming lessons or things like that, and so which is not very nice. And how can we eliminate those biases? As healthcare workers, we have a duty to reflect on our biases and educate ourselves on ways to deconstruct those biases. And on a systemic level, education can be introduced in the formal curriculum for healthcare providers. And one of the recommendations in the Truth and Reconciliation findings from Canada was that all healthcare students be educated on Indigenous health issues. The change starts with all of us. Nurses are the frontline care for our patients, and this is where management or your employer can assist. And they can assist by offering e-learnings on culture diversity that you would participate in, and maybe make it mandatory that you would participate in those seminars. One of the courses that is being taught to my students at the college is culture diversity. Students learns about different cultures, not just Aboriginal culture, but different cultures. And over the summer, I developed a section for that culture diversity. It was on the residential school system, and I'm sure everybody heard about the residential school system. And it was very educational to the students. One of the things that I did when I started to do this presentation, was one of the things I came across was the stereotypes that is there in Indigenous population. And one of them was the death of Hugh Papik. He was living in a care facility. The home care workers that were there were not trained in any kind of acute or chronic illnesses. And he presented to them as if he was drunk. But he wasn't drunk. 6 hours later, he died from stroke. So, and another case was I'm not sure what year this was, but it was Brian Sinclair. He was homeless, and he had a urinary catheter in, and he went to his healthcare provider, and he was sent to outpatients for a catheter change and for treatment and also for treatment for antibiotic for a UTI. He had a severe UTI. He was in outpatients or emerge for I think it was 24 hours plus. He was just sitting there in a wheelchair, and the staff that was there thought he was drunk and came in from out of the cold to get warmed up, and he would just move on after. During the inquest, well, anyway, he was found the next day. He was found dead in his wheelchair. He passed away in his wheelchair, waiting to be attended to. And in the inquest, the staff said they never even seen him there sitting in his wheelchair, but when they reviewed the videos, that wasn't true. And this assumption may have been fueled by widespread stereotypes regarding Indigenous alcoholism. I'm Indigenous and I don't drink. So not all Indigenous people drinks. The same as saying that all people from Quebec eats poutine. Culture diversity in Newfoundland and Labrador. Our province is home to many different cultures, including Mi'kmaq, Innu, Inuit, and a growing population of new immigrants. In the course that I teach, we or in the college where I work, we have a lot of immigrants. We have people there from Jamaica. We have people there from Africa. We have people there from India. So it is different cultures are moving into this area. Here in Cornwall, we got First Nations, and it was established in 2011 with a membership of close to 25,000 people, and they're spread across 67 traditional Newfoundland Mi'kmaq communities, and it's one of the largest First Nation groups in Canada. And as healthcare workers in Newfoundland and Labrador, and I'm sure in whatever department you're working in, you will come across an Indigenous person from this group. Also, when I started to do some little bit of research on this one, I wanted to not have all, I was open to have some good things, not all bad things, because there is some good things happening with Aboriginal communities. I picked on Western Health, so I said, what kind of a group, what kind of a department could I get to pick on up there? So I said, well, Aboriginal people is very spiritual when it comes to death and dying. So I contacted palliative care, and I was expecting to get all this. I gave them a list of questions that they could answer for me, and I was expecting, this all not so nice answers come back. But I was really surprised, really surprised. And there are some of the things that I did get back from. They said that Western Health, the spiritual health division, serves as a connection with local Indigenous groups, and primarily Alibu First Nation, because that's the area we're in. And spiritual health as a committee at each of the 6 healthcare sites throughout this region, the Western region. And whenever possible, they always have a representative, Indigenous representative on their committees. Spiritual Health is currently in the process of placing Indigenous altars at each of those 6 sites. And culture leaders are welcome to visit when requested by the patients to practice like smudging or drumming or whatever is requested. And in the palliative care unit here at the Western Long-Term Care, this is the altar that they have there that I really didn't know that was there. And the things that's on that table can be used by the patients in palliative care, or I guess anybody that's in that building can use those. And they also have a healing circle there also for families, residents, staff, whoever want to use it. And the new hospital that's being built now next door to the long-term care also have those Indigenous rituals sites as well. And overcoming barriers to the culture, accessibility, and healthcare. The restrictions imposed by some healthcare policies may create challenges for the inclusion of traditional practices. Some spaces in Western Health site permits the lighting of traditional medicine for the purpose of smudging. However, some spaces require special permission for smudging due to the fire regulations, and that is understandable. Alibu First Nations has provided supplies so that patients and residents can do a dry smudge in their room. And this is helpful when a patient is unable to leave their room for different reasons. And like Vernon said about cultural competence in healthcare, cultural competence includes the ability to deliver care that is respectful and responsive to the health beliefs, practices, and language needs of all the clients. It is also important to understand that not everyone from a particular culture demonstrates identical health practices, needs, or beliefs. So everybody is different. And culture safety in the healthcare means actively inviting and creating a space for cultural expressions within the healthcare. And be aware of your client's special traditions or practices. Respect the client as being part of a culture without attempting to change the client's values or beliefs. And as we move forward, progress is continuously being made regarding deconstructing biases in healthcare and improving culture competence. And examples of that was like in palliative care, what they're doing there in palliative care at the Western Long-Term Care. We still have a long way to go before all individuals are guaranteed a fair and equal experience within the healthcare system. We can work towards achieving this by increasing the amount of cultural diversity training healthcare workers receive both throughout their education and during their career. And I believe that I know in nursing, there is courses being added to their curriculum on cultural diversity. We can commit to being mindful of our own biases and making continuous efforts to deconstruct these views. And we also need to expand the rights and resources of patients in general, and in particular with the Indigenous patients. And we also have to consider ways to better meet their right to receive equitable care and care customized to their cultural needs, because everybody is different. And that would be the end of my presentation. And I hope you're enjoying all the presentations so far. Thank you.
Thank you very much, Brian. We definitely all have implicit bias that we need to examine daily. And thank you for bringing forward some of the positive changes that have been happening in the Western region. I would like to now call upon Megan to do her presentation.
Hi everyone, good afternoon. I hope that everybody can hear me. I will just wait and see if there is an issue with the volume. No, all looks good. Okay, so as Peggy mentioned, my name is Megan Hudson and I'm a registered nurse. My current role is tuberculosis public health nurse with the Nunatsiavut government in Nain, Labrador. I am a member of Nunatuavut and was raised in the coastal community of Blacktickle on the southeast coast of Labrador. Many thanks to Annette and Peggy for inviting me to participate in this panel and education session today. And of course, thank you to each of you for attending this live event and for your interest in the important topic of discussion here today. So throughout the course of my nursing career thus far, discussions around cultural safety, humility, and competency are evolving. The dialogue is constantly growing and expanding to include a diverse range of healthcare professionals. During my discussion today, I will focus on cultural safety in nursing practice. However, the principles and examples presented can certainly be applied to a variety of situations and across other health disciplines. So the iceberg provides a visual representation of the many factors that impact cultural safety in healthcare. So on the surface, there are factors that we observe in our everyday practices. I am sure that we can all recall instances where we observe stereotyping in the workplace. Stereotypes based on where a patient or client lives or calls home, the color of their skin, and so on. You may have overheard a coworker making a comment about a particular client as they enter the unit or the office. Sometimes we find ourselves thinking or expressing those comments based on our preconceived biases. Think of a situation where you witness stereotyping in your workplace. For most people, it probably made you feel uncomfortable. Perhaps you felt that it was unfair or unjust for someone to make those assumptions about someone that you have not met. In most cases, we probably do not challenge those internal feelings or a seemingly simple and harmless comment made by a colleague. We move forward and begin to provide care to our patients. What we may not realize is the impact that a seemingly simple stereotype can have on patients and families, the impact on building rapport and trust, and the impact on the care provided and health outcomes for that individual. So let's think deeper. Consider the stereotypes that we witness. Think of how this bias impacted or could have impacted the procedure of care, the differential treatment that was provided, the inability to develop a therapeutic relationship due to a hostile work or care environment, or the lack of culturally safe care provided because we or a colleague were providing care based on a bias and a preconceived understanding of who the patient was, why they acted a particular way, and us assuming what they needed in order to regain health and wellness. It's okay to admit that we have been there, that we all hold unconscious bias. When we reflect and challenge those biases, we dig deeper and we see beyond the surface or the tip of the iceberg. Then we can examine a broad range of factors that impact cultural safety in healthcare. Beneath the surface, consider how grooming of staff to hold biases impact care. Based on years of organizational procedures, consider a history of healthcare provision that did not explicitly focus on the intricacies of cultural safety. Consider age-old policies and procedures that are generalized and do not make space for cultural considerations. Regardless of the position or role we assume, it is so important to understand the complexities of culturally safe care. It is vital that we look beyond the surface and think critically to identify personal, collegial, and organizational barriers to providing holistic and culturally safe care to all. So what do nurses need to consider in culturally competent care? A few things to consider are Code of Ethics for registered nurses, the standards of practice for nurses and nurse practitioners, and self-reflection and continuing education. So first, the Code of Ethics for registered nurses as presented by the Canadian Nurses Association. I just wanted to reflect a little on a couple of our key documents that we refer to in our nursing practice. And sometimes, we may have been directed to these documents quite a bit in our nursing training, but may not have visited them so often afterwards. But key to reflect here and note that, among the 7 nursing values and ethical responsibilities in this document, providing safe, compassionate, competent, and ethical care is key. We do have an ethical obligation and responsibility to be accountable and to provide that competent and ethical care. Promoting justice. Nursing ethics is concerned with how broad societal issues affect health and well-being. This means that nurses, we endeavor to maintain an awareness of aspects of social justice that affect the social determinants of health and well-being, and to advocate for improvements. Although these elements are not part of nurses' regulated responsibilities, they are part of ethical practice and are important educational and motivational tools for nurses. Promoting justice, our ethical responsibility outlines that nurses do not discriminate on the basis of a person's race, their ethnicity, culture, political and spiritual beliefs, social or marital status, gender identity, gender expression, sexual orientation, age, health status, place of origin, lifestyle, mental or physical ability, socioeconomic status, or any other attribute. For many of us, we look at this list that I just talked about. This is a long list of attributes, a long list of things that we can focus on a client and make judgments about a client without knowing. It's important that we not do that. Nurses respect the special history and interests of Indigenous peoples as articulated in the Truth and Reconciliation Commission of Canada's Call to Action. That's outlined in our Code of Ethics. Next, considerations around our standards of practice for registered nurses and nurse practitioners. So the mandate of the College of Registered Nurses of Newfoundland and Labrador is to protect the public through self-regulation of the nursing profession in accordance with the Registered Nurses Act. The authority to set standards reflects the CRNNL's primary mandate, and the standards of practice establish the regulatory and professional foundation for nursing practice. So, for example, in Standard 1, responsibility and accountability, nurses are expected to recognize and take action in situations where client safety is potentially or actually at risk. In Standard 3, client-centered practice, nurses must respect diversity and promote cultural humility and a culturally safe environment for clients and members of the healthcare system. My point here is that these things are clearly outlined in our ethical responsibilities for our practice. They are clearly outlined in the standards of practice that are expected for us to be accountable for in order to maintain a license and have that privilege to provide care to clients and families and communities. So why isn't culturally safe care often held to the same high regard as other aspects of care? Why is this standard so often neglected or not treated as importantly? Self-reflection and continuing education are certainly key, and we've heard that from all of our panelists here today. Self-reflection exercises are definitely key. So a core aspect of cultural safety is examining our own cultural identities and attitudes, and being open-minded and flexible in our attitudes towards people from cultures other than our own. Identifying what makes someone else different is simple. It's easy to pick out what is different about somebody else. Understanding our own culture and its influence on how we think, feel, and behave is much harder. A good place to start your cultural safety and humility journey is with self-reflection. So self-reflection is something that not just us as nurses, but I think all healthcare providers are encouraged to do, throughout our nursing training and other health professional training, but we are encouraged to do that and reflect upon our practice throughout our career. It's something that takes time. It's something that can be quiet and not group-based, but it is something that's important, and it is us showing accountability to our practice. So the picture here on this slide, it's the cover of a resource from the College of Naturopathic Physicians of BC in 2021, and it is attached in the resource section and can be taken back to your respective workplaces for personal use. Feel free to share this with your colleagues. It's a great resource and asks some really great questions. There's space to fill it in. I really encourage people to do it. I did it leading up to providing this discussion today, and it wasn't easy. Some aspects of the questions were easy, others were not. Just like I mentioned previously, it is a lot easier to pick out what is different about somebody else than to reflect on our own biases and perspectives sometimes. But it is really important. So taking that time is certainly key in being able to provide culturally safe care. So this work, it is professional development, and it can be used as hours for our continuing competency program with the CRNNL. I know oftentimes we are searching for an online webinar such as this or some type of formal education event in order to, continue our professional development or get those hours for our CPP. But remember that this type of professional development is not only applicable to CPP, it is invaluable to our nursing practice, to our personal and to our professional development. So what are some examples of cultural humility and safety that have made a difference in practice? As Brian stated before, it is really important to focus on those things that work, just as much as the things that don't work or have been negative. Oftentimes those negative experiences and things that we have witnessed, provide a teaching moment, but it is really important to focus on what we are doing well, but also how we can do it better. And again, that comes back to self-reflection. There's always room to grow and learn and reflect on what we've been doing. So respecting communication and building trust. It sounds simple, sounds like the basis of what we should always do with any client. However, being respectful, being nice, being kind, we think those are normal attributes of a healthcare professional, and they should be. But without examining our own biases and without self-reflection, we're really not able to do that as effectively as we think we might be. And I think it's really important to realize that we all make those mistakes. And, as Chief Hart had mentioned earlier, it's okay to make those mistakes. People will kindly correct you and help you learn. But I think that willingness to learn is what's really important. So respecting communication and being open to listening. We're often very consumed with time constraints and a to-do list of things that we need to do in a run of a day. And we're taking care of other clients, and we have meetings to get to, and we have a whole list of things that we need to do. However, sometimes when we focus on that to-do list, it's really easy to miss out on that opportunity to listen and to learn from that client. And sometimes listening is one of the most important things that we can do in building trust and a good rapport with that patient or family. A willingness to learn about lived experiences and cultural practices. Instead of making assumptions about what somebody's cultural practices are because of we know where they're from or what Indigenous group they identify with. So as Jessica mentioned, it's okay to think of including specific cultural practices and activities into a plan for a client, but let the client identify that. Just because a client belongs or identifies with a particular Indigenous group does not mean that they explicitly relate to or practice all of those activities specific to one culture. Listen to your clients. Listen to their experiences. Be curious as opposed to assuming. Be curious and learn. Identify barriers to safe and competent care. For example, language barriers. It's okay to ask people if they speak English. It's okay to know that English may not be somebody's first language in this province. That's okay. The important thing is to understand that and navigate that and show respect during that. So identifying translators, interpreters within the healthcare system, wherever you are in the province. It may be an acute care setting or a community setting. There are people that can help. Being resourceful. A big part of our practice is about critical thinking. If that person or service that is available to help, if we're not aware of it, we can't utilize it. So looking for that knowledge, looking for that information and having that in our little, in our pocket, as I like to call it, is that we have this little pocket full of all these resources and ideas that we can pull out when we need them. When we know about the interpreters and the Friendship Center and the resources that are available, maybe through a particular Indigenous organization for that client, when we can pull out all of those resources, then we can work collaboratively to provide culturally safe care. And flexibility in care planning. I think, again, this really goes back to self-reflection and identifying our own biases. If we approach client care with a policy that has been created by an organization that has not created the space to focus on culturally safe care, we are going to provide routine, standardized care for that person without any other consideration. And that's really what we want to get away from. There may be a specific and evidence-based way to perform a particular dressing change or insert a catheter or do all of these other clinical skills. But the communication and the relationship that we build with a client and family while doing those specific tasks, that's what's important. And that's what a family, that's what a client will remember at the end of their interaction with the healthcare system. And advocating for inclusive and individualized healthcare. I think the gap sometimes that happens is that I think we're all guilty for it sometimes. We all assume that it's somebody else's responsibility to advocate. I'm just a frontline worker. It's not my job. I think it's my manager's job to do that. My manager might think that I'm in middle management. I don't have a lot to say. It's my director's job. The director may think, you know what, I've got enough to do. I'm going to leave that to senior executive. That's really their role to be advocating for things at the government level. It's all well and good to think that. Really, it's protecting ourselves and not putting ourselves out there. We all have a voice. We all have a duty to use it as we provide culturally safe care for our clients. We may not be the person that is at the bargaining level with a government body to make direct change in policy, but we do have a voice to start the conversation, and that's certainly what's important. So I certainly challenge everybody on the call today, including myself, to continue to, go back to our practice and really be mindful and respectful, but also to ourselves in our practice and in self-reflecting and really asking ourselves those tough questions. Because oftentimes it means us being uncomfortable to provide a more comfortable space and safe space for our clients. I just think that if we are uncomfortable doing a self-reflective exercise, just think how uncomfortable it must be for Indigenous peoples and people of other cultures who come through the healthcare system and feel culturally unsafe while they receive care. I think we can take some time out to be uncomfortable too, even if it's just to self-reflect in a quiet space. So I hope that we can all move forward doing that and having more conversations like this, because this is certainly the groundwork for all of that. So I thank you again and appreciate your time.
Thank you very much, Megan, for your presentation. And thank you for bringing forward how cultural safety and cultural competence is in the standards of practice and code of ethics for many healthcare professionals, including registered nurses and licensed practical nurses and social workers and nurse practitioners, among others. And how we really need to take that minute to reflect on how to communicate and provide that culture of safe care. So it is my pleasure now to call Chief Misal Joe to provide his insights.
And such an incredible topic. I just first want to take a moment to remember all the murdered and missing women that's out there, that and their families, and of course the young children, all the many children that were found from the residential schools. It's traumatic time for all of us, and we all feel the hurt and pain. And I know their families have, after generations are going through pain, and that's something that we need to be always aware of and remember every day, because it was such a traumatic time. I certainly enjoyed listening to the conversations, and it's all incredible. I don't know what I can add to that'll make a difference, and I just want to say this to Chief Hart. You got your 3 terms under your belt. I'm heading into my 45th years of being chief in this community. So I started here when we lived in deplorable conditions, rich in culture and traditions, but deplorable conditions nevertheless. When I left there at 16 years old, I basically ran away from home. My dad didn't want me to go, and when he went to work, I just left, got on an old coastal boat, and went away. That was one of the best decisions for me that I could ever make. The education that I got from that was something that you can't get in any institution anywhere. And I traveled across the country and visited many of Mi'kmaq people in the Maritimes and across the country. And I found out that in some cases they were very, very far ahead from where we were at the time. And there was other cases where there was Aboriginal communities that was poverty stricken in many ways, like our community. So I came back here in 1974, and we had just started to build a community. So we actually been building a community up to present day, and we have really faced all the many things that you've talked about. The previous speakers have talked about, to the hospitals, to the doctors and the nurses, the healthcare providers. Not as much today as it was back some time ago. I've got the personal experience of a doctor asking me where I was from. I said, Conn River. He said, well, you drink beer, don't you? You smoke? I said, no, I don't drink, I don't smoke. His remarks was, well, I thought everybody was a drunk in Conn River. So those are the kinds of things that sometimes you get from going in to see a doctor, or sometimes even a nurse. And not as much. Things are changing. But you also got to keep in mind there's a fear factor involved with our people too as well. And that fear factor goes back, for 500 years. And trying to outlive that fear, that was imposed on our people through the governments and the Europeans that arrived there and the clergy is still with some of our people and is still around. How many generations do we have to live through that to overcome it? Fortunate for me, I refused to go to high school. I refused to go to church. So I didn't get that kind of influence. I preferred to strike out on my own and do my own kind of education. And in doing so, I ran into lots of racism, lots of prejudice, and a lot of good people too as well. But at the same time, you have to meet about 25, 30 good people to overcome the shock of hearing one negative word sometimes. And sometimes it leads for sleepless nights. And one is, do you lash back at people? Do you fight back? In my earlier days, yes, I did. And today I look at more along the lines of what's happening here about in terms of how we deal with those issues. And it's through education. Education in our schools, education, starting from K to 12 and on into universities and colleges. If we don't do that kind of education in terms of cultural differences and cultural identity and traditions and the language, different language that's spoken in Newfoundland, those are things that was never taught in our history. There was one little paragraph in history books in grade 5 that says, people, actually at the time we were called Micmacs, were brought to the island by the French to kill the Bialik people. That's a European myth that was still in the book somewhere along the way. It had never been taken out. So we live with that every day. That's the things that we live with. And I think Brian mentioned there was over 20,000, 25,000 Mi'kmaq people in Newfoundland, and there's more than that actually. You count Newfoundland, you count Conn River and Qalipu First Nation. We have 1,000 people on reserve, and you have 25,000 with Qalipu First Nation. We have 21 more of our people off reserve. Some of them we don't know. They live all over other parts of Canada, but we try and keep in touch with all of them, however hard that is. But when we took away the school from the church, actually took away the school from the church in 1985. And I remember the negotiations at the time of saying to the school board, and a priest was the chair, and he asked me, he said, "What do you plan to do if you take away education from the church? Are you going to spend your money on booze and alcohol?" And it's because you don't know absolutely nothing about education. And the only response I could think of at the time was basically, well, we can't do any worse than you've done, Father. And we did get the church, the school, the church, the property that was taken from our people. And only a short time later, and at the time, I remember saying to myself, damn, I'm a good negotiator. All I got to do is ask and things just fall into place. But it was only years later when I got older and being able to look back at that time and see that we didn't get the school to take over the school and run the school back in 1985 because they believed we could do it. They simply did it because they thought we couldn't do it and would have to give it back in a short space of time. Since we've taken over education from the church in 85, we now are putting out of our school every year anywhere from 10 to 15 people that are graduating every year going off to higher education. Some are going off to technical colleges and universities. We have lawyers, we have doctors, we have nurses. Those are things I don't think we could have accomplished if we stayed on the Catholic school board. And it was a rough go. We never had a residential school. We had day schools run by the church, and I know from what I hear and people I talk to how tough it was in residential school. Well, we were the next best thing to a residential school with teachers that come in from the outside. You went to school to be afraid. You didn't go to learn because you went to be afraid. The beatings that took place every day, it's cruelty, made to kneel on your hands for hours on end, made to kneel on a pencil uh, for hours, made to crawl up and down the hallways on your hands and knees, made to kneel in a corner um, because of something that the teacher thought you did wrong. Have you, back when I went to school, that's a long time ago, but at 7 years old, you wasn't required to go to school until you're 7 years old. And when you go to school at 7, you can't read or write. You spend all your time living outside with your parents, your grandparents. So when you got to school, you became the mark for being stupid because you couldn't read or write, even though there was 7 grades in school. But each person that came through had that same tag on their head that you're stupid, you don't know how to learn, you don't know how to read, you don't know how to do anything. So you're put back in a corner until you learn how to read. And I actually didn't learn how to read for a long time until my grandfather, whether he knew what he was doing or not, gave me a comic book. And I think within a space of 10, 15 minutes, I was able to read the comic book, and it started from there. And from then on, I read everything I get my hands on, even catalogs and anything I could find. I love to read, but it just, to me, is the key to some of the things that we're faced with today. Is the fact that we need education in our schools, we need education in our universities, we need education in the colleges, and even in our own schools. We need better education in terms of dealing with the outside world. Uh, Going to a school in a small community from K to 12, you're going to be missing a lot of things in your life that you're going to be into the bigger world. So what we started doing some time ago was taking grade 10s, 11s, and 12s into Grand Falls, St. John's, other places that had universities and colleges, let them go in and take a look and see what they're being faced with somewhere down the road. Also to take them into some of the bigger businesses in St. John's and let them talk to some of the CEOs and their staff. And from that, some of our people then went on to become workers of those organizations, went on to work within the university itself. So we've learned how to live in two worlds at this stage. We've got no choice. We had to. In order to survive with our language and culture intact, we have to learn how to live in two worlds. One is the Aboriginal world, where we're safe and comfortable and we know everybody. And the other world is the outside world, the white world. And we know that there are incredible people out there, but also a lot of people that are not so incredible. So that's what we have to deal with. And when we come across those people that are very racist and prejudiced towards us, we now learn that we need to educate as best we can. My first stop when I left home, when I ran away from home, was Halifax. And I was asked by the individual at a rooming house, he said, "What kind of Indian are you?" I said, "Well, I'm a live one anyway." He said, "Well, I thought we shot all you people in Newfoundland. So how do you escape?" I said, "Well, I think you might have been mistaken in terms of the Yupik people and Mi'kmaq people." And, being faced with that all your life, it takes a toll on you. It takes a toll on families. It takes a toll on how you approach the outside world, how you approach government. Because you got to keep in mind, it was a government that allowed people like Cornwallis to put a bounty on our heads going back to 1749. And it was the churches that encouraged that. It was the governments that encouraged that. So we're trying to overcome all of those things in our lives. So when you're sitting down to talk to government, whether it be the civil service or the politicians, in the back of your mind at all times, it's going to be those things that you've learned, you inherited from your people that go back 500 years. And those are the things that you don't dwell on, but it's there nevertheless. And taking over our own school was a blessing because we was able to teach our children our own history, which was never taught before. It was never taught in the history of Newfoundland or the history of Canada. Quoting Chief Dan George, the buffalo was more important to the history books than Aboriginal peoples in Canada. Well, like so in Newfoundland. I think the early explorers and the animals that they saw here was more important than our people that lived on the land and survived on the land all their life. And those are the things that we talk about in our schools. We talk about the language. We're trying now to recover what was lost of our language, however difficult that is, because we had a priest that was there in 1920s that outlawed the language. Our people spoke the language in 1920s fluently, and we had a teacher that spoke Mi'kmaq and was teaching our children how to speak Mi'kmaq. And one priest, and not church, but one priest decided that he would outlaw the language and the culture, the tradition, whatever he can get his hands on, and banish from this community the chief and his family. And so those are the things that we can teach our children. History is history. We have to teach our history. We have to teach your history, because when our children go out into the world, they go into the bigger world, particularly universities. They have to know and understand the history, our own history, and they have to understand your history. And the two histories do come together. Sometimes not in so good ways, some other times in good ways. But nevertheless, that's part of what we call living in two worlds. And I don't know what else I could tell you. I don't have notes. I'm just speaking off a lifetime of living in this place and a lifetime of living with trying to make this place a better place for not just for our people, but for all people. Even though sometimes as frowned upon as being greedy. Like, for instance, I'll tell you this. In Newfoundland, we're not part of a treaty. The treaty only applies to Mi'kmaq people on the mainland. We was told by Chief Justice Leo Barry that if you want to practice treaty rights, you have to go to Nova Scotia. You're immigrants to Newfoundland, and that's not true. That's just another myth that that's been used by Europeans going back a long, long time. And when we first started to going into commercial fishing in Newfoundland, we ran into many, many, many days of racism and prejudice. It had the guns pointed at our fisher people. We've had fishermen say to our people, "We should have shot all you guys back when, not just the one group, but everybody." And those are the things that we talk about, how to overcome that and how to deal with that. When our young people go out into the world, they're going to be faced with that same prejudice. You may not face it in hospitals and clinics, but you do face some of it, but more so on the outside world. In the workplace, for instance, it's getting better through our own education, our own discussions with people that we're in business with. But it's still there, and I don't know if it will ever go away to where, in fact, it's all gone. But what we must do, and always do, is to keep talking about the change that needs to take place within the government, within the churches, within the workplace. And if we make that a part of our priority of happy wellness in our community, then I think we can do good. But excuse me, we do have I guess the medium today would be the television and the iPads and the phones. So it's difficult for us today dealing with all the stuff we have to deal with because out there is so many things coming at our young people today that if they're not being taught right at home, they're not being taught all the things at home, then their teachers are going to be the television. They're going to be the iPads, going to be the phones. And so that's why I say we need to make sure that our families are well looked after. Education that we get in our communities got to be better than they can get anywhere. And the fact that we can now teach the language to our children, and also that we are now looking at an immersion program for the community. And we're getting there. It's taken us a long, long struggle to get here, but we're here, and we have our own clinic that's fully staffed by, I think, 3 or 4 nurses around the clock care. We never had that growing up, and I think somebody mentioned tuberculosis. Well, I grew up in the tuberculosis time, and I remember a large part of my family being wiped out by tuberculosis. I remember the old Christmas seal that came around the coast of Newfoundland, and going aboard the old Christmas seal to get scratches or something for tuberculosis. In every disease that was known to man have come around, and we've got shots and pills and everything for it without having a nurse or a doctor even close to us. The nearest hospital was Harper Britain, and you had to go by boat or you had to walk part the way, and I did that too as well. But it's good to hear what other people are doing, and good to hear what other people are saying. And I know that if we keep talking to each other, we keep spreading the message, we keep educating, we'll do okay. But it'll take all of us together, understanding and appreciating the differences that we have, our historical difference, our cultural differences, our language differences, and how we live different. You know, we have an incredible respect for the land and the water around us, and that's part of. I guess that's part of my Bible. I don't have a written Bible. I would look at the land as being my Bible. It gives me everything I need. It gives me hope. It gives me a time to go and sit and dwell on the past, the present, and the future. It gives me food. It gives me shelter. It takes care of me when I need it. And so I think it's a traditional way of life. And I've been asked many times, what religion are you? And I've always replied, I'm a traditionalist, and then have to explain what a traditionalist means. It simply means that I live off the land when I could. Not as much anymore, but I used to. Growing up, I did. But that's what I mean when I'm not a Catholic or I'm not anything. I'm a traditionalist. I believe that the land itself is of all creation, is what we live by, and we also live by the 7 virtues of life, which is part of our life, and we practice that 7 virtues every day. At least try to. And it starts with love and honesty, humility, definitely respect for all living things and people around you. Truth, absolutely truth. If you're not truthful, if you don't preach the truth, you don't talk the truth, then your credibility will be gone forever. And patience with ourselves. Sometimes patience that you don't lash out at people that are saying the wrong things at the wrong time, even our own people. And patience enough to be able to educate rather than to strike out in a negative way, because negativity only attracts negativity. And the last one, of course, if you lived all 7 virtues, you become a wise person or an elder. And I can honestly say that I don't know if I'll ever get to that stage of being a wise person or an elder. That's not my call to make, but at least I try to live that way all my life. And that's part of what we're talking about today too as well, is all of those 7 virtues come into play in what we're talking about today. And that's been my education over the last 75 years almost now at this stage. And I hope that I live long enough to learn many, many more things about myself, about my people in this community, about the people around me, and the people in this country. Uh, we become, at this stage, we become the teachers of our own culture. We don't rely on the Europeans or the colonizers any longer to give us their version of our history. We need to write and preach our own history and to tell the world about what we do as people, how we live, and what heals our heart and soul. It's not always the white man's medicines that will heal our heart and soul. What heals our heart and soul sometimes can be a simple thing as two eyes seeing or two ears listening, or the ability to sit and listen to someone tell their story. That's a part of what we talk about and part of what we do. That's part of a healing practice that's been the thousand years that's been there. When all else fails, sit in a circle with people, and many things will unfold, and much healing will take place. And those are the things now that's come back to our culture that was gone and outlawed for many years. Because we were the first group of people to be hit the hardest by the arrival of the Europeans, we lost more fast than anyone else. If you look at some of the things we're doing today, it's been brought back from central Canada, where the earlier Europeans no longer getting to that part of Canada. But we, on the east coast of Newfoundland, lost more faster. And so we had to adopt many things into our culture that was long taken from us. Split light ceremonies, for instance, sweetgrass ceremonies, drumming circles, all those things have been adopted by us from other places because it was gone from this province for such a long time. Only in the memories of much older people can they tell you about the ceremonies that we had and what we practiced and now don't because of the churches and government. So it's sometimes amazing that we've lived this long, this healthy, in this place because of all those things that came out like a thunderbolt. But we have survived. We will survive, and we will grow stronger. And I think, as Ryan said, there's 25,000 Mi'kmaq people in his band. There's 1,000 people in this community and 2,100 people off reserve, and that's not counting Newfoundland. You're talking about the largest group of Aboriginal people in Atlantic Canada, or in Canada for that matter. And I think somewhere along the way we have to learn that we need to be speaking with one voice to be heard. Because if we do it individually, I think we can be so easily pushed aside, and we don't want to deal with that. And racism comes in many different forms. It took us 25 years to gain recognition from the federal government. It's taken us 10 years to get an agreement with the province of Newfoundland for forest management agreement. Every new government that came in the last 10 years or so said, oh, it's all done, it's going to cabinet. It's been lies upon lies upon lies. That too is a form of racism and prejudice. So it's not just not the healthcare system that's in cahoots with prejudice and racism. It's out there, and I think it's up to us to deal with that. And I'll tell you one last thing in terms of racism and how little people living in this province know about us as Mi'kmaq people, whether you're from Corner Brook or you're from Clark's Beach or you're from Maui-Boquet. I was flying I flew out of Ottawa and got stormbound in Halifax. And back then, Air Canada used to get an hotel for you. They don't anymore. And so I had to get a cab down to downtown and get a hotel. When I was passing by between a cab and a limousine, the guy said, "You want to take a limousine down wherever you're going?" I said, "No, it costs too much." No, he said, "It's only costing $5 more than a cab." I said, "Okay." So I jumped in the back of the limousine, and on the way down, he asked me where I was coming from. I'm coming from Ottawa, and he said, "Oh, where are you going from here?" I said, "I'm going to get a hotel." Oh, he said, "Okay." And he said, "Is this home for you?" I said, "No, Newfoundland. I'm going to Newfoundland." He said, "Oh, where are you going in Newfoundland?" And I said, "I'm going to Malibu at Con River." "Oh, no, no, no." He said, "You don't want to go there." And I was silly enough to ask why.
Well, I think we lost our last speaker there. I think we lost Chief Joe. If we get him back, we'll see now in a minute. But if not, I hope he can still hear, because I'd like to thank him very much for sharing his experiences and telling us his stories. Even though I didn't hear the last answer to that last story, and really talking about the importance of education and that how education has to be at all levels and it has to be continuing. I am now going to pass the webinar over to Annette, and she's going to provide some concluding remarks.
Thank you, everyone. And I just want to say a huge thank you to our wonderful panelists today, Vernon, Chief Hurd, Megan, Chief Joe, Jessica, and Brian, for this informative, meaningful, and stellar presentation, and for sharing your knowledge and expertise and experiences with us today. You each talked so passionately about the collaboration that's needed, and the respect, and the ongoing dialogue, and the need for continuing education, and just the need for those continued conversations that we really hope sparked something in you today from attending. Spark your desire to learn more and to do more, so that people, who are experiencing, services and are accessing services, truly feel that it's one that's built on respect and collaboration. And through our individual practices, we can certainly make a difference, and we can strive to provide inclusive and high quality services. And as Megan said too, we can also be leaders in informing systemic changes and issues, that are needed to be addressed in healthcare and in health and in social systems. So I don't know if we've gotten Chief Joe back yet. It seems like he's still offline, so that's unfortunate, because I would have loved to hear the ending of that story.
Me too.
And just a note, as people do start to sign off, the PDFs of the presentation is available on the platform. We did have a couple questions on where to access the handouts. So again, they're in the handout section of the handout widget section, and that take a moment to complete the evaluation form. That's also going to come up, because that's invaluable. But I just want to say again how invaluable this experience was, right from the planning, when myself and Peggy and Wanda got together to look at a topic for this year's 19th session that we've been doing this partnership. So that's fabulous, and so grateful and honored that each of our panelists were able to join us here this afternoon. It truly was a great learning experience for everyone, and a very meaningful experience. And I guess just to note that social workers may claim 2 CPE credits on the required category of workshop for attending the webinar this afternoon. And Peggy, did you want to address the CE credits for RNs and LPNs?
Yep, so on the little button in the middle on the green widget, there's a certificate that you can print. But RNs and LPNs can use just their webinar registration or confirmation email, or that certificate of attendance, and that could be used for your confirmation, and this was 2 hours.
So thanks again, everyone, for joining us. I wish we had another hour together, and to kind of go back to each of our panelists and to have some more discussion. But I'm sure this is not going to be our only opportunity, and we'll continue to build those collaborative relationships as we look at enhancing, our own cultural competency and how we work with our Indigenous partners, but also with clients and populations and people from diverse cultures. So Thank you, everyone. Enjoy the rest of your day and stay safe.
Bye now.